Thank you, AIOS, for giving me this opportunity. It's nice to be presenting in presence of your mentors. So I'll be touching upon some studies about the primary angle closure. So I pulled upon and found out a few RCTs, the randomized control trials. So I'll be touching upon the RCTs on LPI versus PSCS, the Zhongshan and the Sinha analysis, the argon laser peripheral iridoplasty in PAC, and the cataract surgery in PACD. So we'll just touch upon these studies and what recommendations we can imbibe from them. So Zhongshan angle closure prevention trial, the ZAP trial, was a single-center randomized interventional control trial, and this was a population-based study. And they took occludable angles as the patient's kind of inclusion criteria. Since it was a population-based study, there were a large number of people. They were screened, more than 10,000, and approximately 889 patients were included in the trial, where one eye was laser was done, and the other eye was followed up over a period of 72 months. So the primary endpoints here were the pressure of more than 24 millimeters of mercury on 2 occasions, developing at least 1 clock hour of PAS or an acute attack of PAC. So there 75% of patients completed these trials, and they found out that 19 patients in the LPI groups as compared to 36 patients in the control group did reach an endpoint. And the cumulative incidence of conversion of PSCS to PAC was 4.19 per 1,000 eye years versus 7.97 per 1,000 eye years in the observation group. Then we move on to the, sorry, I just went on fast. Then you move on to the next trial, the Singh analyst trial, the Singapore asymptomatic narrow angles laser iridotomy study. So this was a multi-center randomized control trial. This was a clinic-based. 480 patients were involved. They again took bilateral asymptomatic PACS into the inclusion criteria. And out of 1,000 patients, 480 patients were included into the 2 groups. Again, one eye was lasered and other was observed. So they took half clock hour as the endpoint into the half clock hour of goniosynic as a PAS as the endpoint, along with the pressures of more than 21 millimeters of mercury or development of acute ACG or a PAC. So what lessons do we learn from what this study talked about was at the end of 5 years, 5% of LPI patients developed an endpoint as compared to 9.4% on the control group. And the incidence of reaching the endpoint was 11.65 per 1,000 eye years in the LPI group as compared to 21.48 per 1,000 eye years in the control groups. So what do we learn from these RCTs? So LPI itself was a safe with no long-term adverse effects, both the studies talked about. LPI had a 47% reduction risk of developing PSCS to PAC in the ZAP trial, and majority the endpoint was development of the peripheral anti-synic. So LPI does have a modest benefit in preventing progression of PSCS to PAC, but due to low incidence of conversion, the immediate threat to vision is not there because most of the patients, the endpoint was development of PAS. And the rate of developing angle closure endpoint was less than 1% per year in the ZAP trials. Now the number needed to treat in the PAC, number needed to treat the PSCS patients to prevent from PAC in the ZAP trial was approximately 44 over the period of 5 years, and that was 162 to prevent the patient who's having a sight-threatening glaucoma if you want to prevent that. As per so both the analysts and ZAP trial compared the incidence, which was much less than what we found in the Indian studies. So in the Indian studies, we had the higher rate of conversion from PAC to PACS. Probably this was because of the difference in the definition used for PAC as compared to, because we just talked about the development of PAS as compared to the number of clock hours. Also, these trials talked about the more protective role of laser PI in conversion of PACS to PAC in the Indian studies. Now we talk about the role of ALPI in acute PAC. So there were 4 randomized trials which talked about ALPI versus medical management in acute PAC. So both ALPI and the standard treatment group used topical pilocarpine till the iridotomy was performed. The baseline IOP the baseline IOP, the IOP at the 2 hours, and the final IOP was better in the ALPI group. The IOP percentage reduction was also better in the IOP ALPI group. The duration of attack had no impact on the IOP reduction. There was no significant difference of changes in the PAS formation, the CDR, the change in the endothelial cell count, or the requirement of medications post ALPI or the laser group. So both ALPI and systemic medications were equally effective in controlling the IOP, but ALPI lowered the IOP rapidly. ALPI in acute PSCs may have technical challenges with the risk of corneal burns, so LPI should be considered as a first choice after control of IOP in most cases. ALPI may be used in patients where LPI is not able to adequately control, more so in cases of plateau iris control. Now we move on to the role of cataract surgery after acute PSC. So this is a randomized controlled trial which talked about early phaco plus IOL compared to LPI after an acute PSC. So there were 62 eyes in the two groups. Half of them went in for phaco and half of them went in for laser PI, and 30 completed the 1.5 years of follow-up. So phaco group had a lot of complications, including post-operative reactions, visually significant PCOs, corneal edemas, posterior capsular ruptures. LPI also had risks of closing LPI and having small iridotomies which needed supplementary laser later on. Another study talked about initial management of acute primary angle closure with phaco compared to LPI. So here again, the patients were divided into two groups. 18 went in for LPI and 18 went in for cataract surgery. The endpoints were the rise in IOP from 20 to 24 millimeters of mercury or 25 millimeters of mercury after 3 weeks of surgery, or loss of light perception. They also talked about qualified and complete success in terms of medication use. So they found out there were higher failure rates in LPI as compared to phaco-IOL groups, and 7 patients in the LPI group underwent a phacotrabeculectomy for non-control of IOP. So the lessons we learned here was the IOP, phaco-IOL was more effective in controlling the IOP, but there was a lot of complications, and the phaco-IOL was a technically challenging job in patients who had an acute IOP in the acute ACG in the recent past. They had problems of cloudy cornea, shallow antechamber, poor mydriasis, and zonular weakness. So the beginners may find it difficult to do surgeries in these patients. Then we also had a role of early lens extraction in PACD. Again, this was a multi-center randomized comparative effectiveness control trial across 3 centers in 6 countries. So they talked about phaco in patients who had pressures of more than 30 millimeters of mercury or PACG. They excluded symptomatic cataracts and also advanced glaucomas. Synechiolisis and laser iridoplasty was also allowed whenever it was required. The outcomes in IOP, in terms of IOP was not great, but there were increased risk of complications in the CLE group along with the increased mean cost in the CLE groups. So this is the comparison of IOP in the both groups, which was not significant after a particular time. So what we take on from this study is there was a more modest benefit of IOP reduction in CLE after PAC in early PACGs, but LPI still remains the first line of treatment in view of complications because of the phaco. There are many RCTs which talked about the lens vault and the lens thickness. They are all required to find out the patients who will have more benefit from phaco as compared to LPI. Thank you.
Thank you, Dr. Ankur. That was well summarized. But it's important to realize that these are all population-based studies, and in our clinical situations, especially patients who come from remote areas, we may have to modify our approach depending on the current situation. Especially when it comes to lens extraction, the EAGLE study has been quoted a lot to promote the use of clear lens extraction, but a lot of them actually had mild cataracts, and if you look at the difference in the entire group at the end of 3 years, there wasn't much of a difference, about 1 to 1.5 millimeter mercury at the most. So whether it's clinically significant, I don't know, it was just studied